Okay, so now we're moving forward to gynecologic neoplasms. So there's a bunch of them, and back in step one, this was actually a very annoying topic, much harder for two reasons. One, it was brand new stuff, and then the second issue was that there were just too many. So many all of a sudden. You think if you're going down from top to bottom, then by the time you would get to the end, you would hope, to have lesser things to worry about. But reproductive and respiratory are both extremely problematic, huge topics. There's the step one breakdown right here. So we have the non-neoplastic stuff, which we kind of already discussed. We talked about the Bartholin's cyst earlier. Um, and then lichen sclerosis and lichen simplex are two other less high yield for CK, much more high yield than step one. However, of course, you can still get these topics as a CK question as well. And of course, the CK book doesn't really talk about them. And then you have your neoplastic things, which right here we're only looking at the vulvar things, but there's also, as we keep going, there's going to be the HPV related stuff, and then the ovarian neoplasms as well, which have their own breakdown, making them very, very annoying because of the diversity in answer choices. So we're going to be looking at all of this as we keep going. So the first thing they talk about are your fibroids, uterine leiomyoma. Now we talked a little bit about uterine fibroids when we were discussing adenomyosis and endometriosis, both of which had the physical exam aspect, where when you would do the physical exam of the uterus area, then there would be no bumps. It would either be uniformly enlarged, such as in adenomyosis, where the glands are moving into the myometrium. So of course the whole thing, the whole uterus feels bigger. And then endometriosis, where the gland isn't going into the muscle, but rather moving from the uterus to the other intra-abdominal areas. So of course the uterus is pretty much normal size in those patients. Here you're going to do a physical exam and you're going to feel the bumps that the fibroids are forming. And we discussed that because of the amount of space they can take up, there's different kinds of symptoms that they can yield because of the location of the fibroid, which is what this new world image on the right side is kind of depicting. Gynecologic cancers include uterine, endometrial, ovarian, cervical, and vulvar neoplasms. Ovarian cancer carries the highest mortality and it's extremely dangerous. The most common benign neoplasm are your fibroids. They present as discrete, round, firm, and often multiple tumors composed of smooth muscle. Very important to remember that these are just smooth muscle, where you're going to have these as answer choices. It'll just describe it as smooth muscle and connective tissue. So smooth muscle and connective tissue, and may cause infertility or even menorrhagia. Fibroids are hormone sensitive, and their size will increase in pregnancy and decrease after menopause. Malignant transformation to leiomyosarcoma is extremely rare, but of course nothing is rare on your step exam. Prevalence, more common in African American women than in white women, but of course that doesn't really mean too much. Anyone can get it. Majority of cases are asymptomatic until they become too big. So for example, of the various ones we see in this picture, the pedunculated one, pedunculated means that it's on a stalk. As you can see, the peduncle is this stalk right here. It's kind of like a tree. The intramural, submucosal, subserosal, and then the subserosal can have three different anatomical locations that can cause problems. So if it's asymptomatic and there really isn't much happening, then it's probably just intramural or submucosal, where as you can see it's just sitting there, but it's not really squeezing anything, it's not causing pressure on anything. The subserosal one often gets tested as a constipation issue. You can see here that it's kind of impeding on the rectum, right? So right here you have the end of your colon, and it's going to block passage of stool. The other subserosal one over here, the anterior one, so this is posterior subserosal. The anterior subserosal one is squeezing on the bladder. It's causing pressure on the bladder, very much similar to how pregnancy would cause pressure on the bladder, right? So every time she has any urine in her bladder, she needs to go urinate. The subserosal one up here, the top one, and then the pedunculated one over here, these are just ones that you'll be able to feel when you do the physical exam. You'll be able to feel pretty much all of them, but these two don't really, the pedunculated and the superior subserosal one, these two don't really tend to cause severe compression of anything, but of course they're still going to be very problematic. Generally speaking, just by looking at the picture, you can tell that one of the easiest things to do here is just to carve it out, right? Just do surgery, just cut it off here and take it out. Same thing for any one of them. Symptomatic patients may present with bleeding, mass effect because of the pressure, as we just spoke about, pain during intercourse or with menstruation, and many pelvic symptoms depending on where the fibroids are. And they can be at multiple locations. A patient can actually have all of these fibroids, as we see in this picture, or just one, or any two. A firm, non-tender, irregular, enlarged, lumpy, bumpy, or cobblestone uterus may be felt on physical exam, which is going to help differentiate this from endometriosis or adenomyosis, as we're going to see in the practice questions. So, of course, diagnosis, as usual, is just with physical exam. Once you really figure out that you think it is fibroids, then you can confirm by doing ultrasonography or even MRI. Ultrasonography, transvaginal ultrasonography, will look for uterine myomas and can also exclude ovarian masses, which is great, right? So this is cheap to do, it's easy to do, and you'll take care of excluding a much more dangerous cause, ovarian masses, because you know ovarian cancers can kill people. MRI can delineate intramural, subserosal, and submucosal myomas. Best modality for visualization, usually reserved in preparation for surgery, right? So you've already done your physical exam, now you have a very good suspicion that it's fibroids. You do the ultrasound to pretty much confirm it is fibroids, and then when you're about to do surgery, if you're going to need surgery for this patient, then you do an MRI to see perfectly exactly where it is, how big it is, what shape it has, etc., etc. And then CBC you would really only do for anemia. You don't really, this isn't something you need to think about too much, because this, generally speaking, are part of the labs you would order for everyone anyway. Treatment, if asymptomatic, then expectant management is enough. You don't really need to do anything crazy. Surgery and stuff you won't have to do. She's okay, right? Anyone asymptomatic, generally speaking, for any step question, the best answer is usually just to give expectant management or no further testing required, etc. Those answer choices. Pharmacologically, you should put them on combined hormonal contraception, because as we said, these do respond to hormones, so higher estrogen and progesterone will make them bigger. Medroxyprogesterone acetate or danazol can slow or stop bleeding, so these are also going to be key answer choices. And then GnRH analogs like leuprolide or neferlin, both of which are high yield medications. Leuprolide was an answer choice a lot in step 1 UWorld questions. Both of these GnRH analogs can decrease the size of myomas, suppress further growth, and decrease surrounding vascularity. However, of course, if you're taking GnRH analogs, you also stop the general menstrual cycle, which means that the patient can't get pregnant while you're on GnRH analogs. And as usual, NSAIDs for any pain that the patient might have. Surgery, well, if it's a woman of childbearing years and it's a patient that wants to have kids, then abdominal or hysteroscopic myomectomy would help. Myomectomy, as we said, is called myomectomy simply because it's made of muscle. So you would go in and just carve these out and get rid of them. Getting rid of them does not mean that she will not develop new ones, but at least in the time being, while she doesn't have them there, she can get pregnant. Women who have completed childbearing and no longer wish to have any more further kids, you would just get rid of the uterus, right? Because all the fibroids come from the uterus. It's from the same smooth muscle, so you just get rid of it. Take out the whole uterus. Uterine artery embolization, 25% will need further invasive treatment if there's uterine artery embolization. Pretty rare thing. This will only be evident because you'll be able to, something in the question will tell you that the uterine artery is not working, and if the uterine artery is not working, then there's going to be issues supplying blood to the uterus itself, and they're going to have to tell you something in the question that's going to be pretty evident for that. Emergent surgery may be required if there's any torsion or around the pedunculated myoma, right? Because things can wrap up around here, right? Blood vessels and stuff like that. Complications, infertility may be caused by a myoma that distorts the uterine cavity and plays a role similar to that of an IUD. So now, in this question here, something really interesting happens. A 44-year-old woman comes to the office for evaluation of abnormal uterine bleeding. She has had intermenstrual bleeding over the past 3 months. Most of the time, she has had only spotting and wiping. But last week, she had slightly heavier bleeding that required her to use a menstrual pad. In addition to this intermenstrual bleeding, she also has monthly menses with 4 to 5 days of moderate bleeding and slight cramping on the first 2 days that typically resolve with ibuprofen. So far the only real thing we're seeing is slightly heavier bleeding. That's about it. She has no chronic medical conditions, doesn't take any medication. She had a bilateral tubal ligation after her last delivery, so that means she's not really looking to get pregnant anymore. She had a bilateral tubal ligation done already. Vitals are normal, BMI is good. Speculum exam reveals a multiparous cervix with a small amount of bright red blood at the cervical os and no visible cervical or vaginal lesions. On bimanual physical exam or pelvic exam, the uterus is small, mobile, and non-tender. So since it is small, mobile, and non-tender, this is not a fibroids question, right? Because if it was a fibroid question, then on bimanual pelvic exam, you would still have a small uterus, but you would find the smooth muscle ball of a fibroid. No adnexal masses are palpated. Hormone levels are normal. Urine pregnancy is negative. So what's the most likely cause of her abnormal uterine bleeding? Well, if the uterus is normal size, then it can't be endometriosis. It can't be adenomyosis. Right? We don't see anything weird with the hormones either. So that helps you rule out a lot of answer choices, after which you would just pick that most likely she probably has a very similar scenario to what happens with colon cancer. So people who have colonic polyps in their colon, also get bleeding in the rectum, right? They get bleeding in their feces, which is one of the diagnostic tests you do. You do the what is it called? The word is supposed to mean that it's hidden. I forget what the word was, but basically the test you order for when you check if there's any blood in the feces, and that blood in the feces usually is something you order because the patient has anemia and you can't really figure out why they have anemia, often with male patients especially, because male patients don't have any menses. So when you order that blood test or fecal test to check for occult blood, there you go, hidden, right? So when you do that fecal occult blood test, FOBT, you find blood and then you do a colonoscopy because you're looking for colonic polyps. Same thing here. She's getting bleeding from her vagina due to menstrual causes, but it's not normal amounts of bleeding in her. So if she's bleeding more than usual, but everything is fine, then she probably has polyps in her endometrium. Right? Same kind of concept as with colonic polyps. So 45% of people picked that. However, 22% of people chose endometrial hyperplasia, which this you can rule out simply because the thing that causes endometrial hyperplasia is estrogen. And if estrogen is very high, then FSH would not be normal levels, right? They didn't give you an LH level, but still, this was good enough. And then perimenopause wasn't really a good answer choice here either. I'm not sure why 22% of people chose perimenopause. So you could tell that 44% of people, which is the other half, chose between these two wrong answer choices. But perimenopause, what even is that, right? And how does that sound like some kind of scenario where you would have excessive bleeding? Menopause usually means no bleeding at all and you're done. So those two answer choices were less likely than endometrial polyps. This premenopausal patient with regular monthly menses and intermenstrual bleeding most likely has an endometrial polyp. They're common, well-vascularized, hyperplastic endometrial gland growths that extend into the uterine cavity. Endometrial polyps typically develop in women middle age. Most endometrial polyps are benign and asymptomatic, but they can cause abnormal uterine bleeding in some patients due to their friability and vascularity. Because endometrial polyps do not affect ovulation, patients may have regular monthly menses with painless light intermenstrual bleeding. Endometrial polyps typically remain intracavity, so patients have a small non-tender uterus and you can't really feel anything because the polyp is inside, right? So there's a polyp like in there rather than outside anywhere. They go on to say that you basically don't have much you can do here. Just treat symptomatic endometrial polyps with hysteroscopic polypectomy. You would just remove the polyp. That's it. Endometrial hyperplasias typically present as irregular anovulatory menses in women with risk factors for excess unopposed estrogen. But she's not obese. She's not taking any other medication that would cause her to have excess estrogen and not enough progesterone. She has a normal BMI and regular menses, so there's definitely no hormonal issue. And perimenopause is unlikely for the same reason, because she has regular monthly menses, right? She doesn't have menopause, so perimenopause is very similar to that. So these two other answer choices were simply ruled out by hormonal issues, and this is a great question to be able to differentiate some of the other things we've already looked at. Now we're going to see a lot of other questions here, so we'll come back to those. But before we look at those, we should definitely get down the rest of the cancers and understand what they're all going to be about. So the next thing here is endometrial cancer. Type 1 endometrioid adenocarcinomas derive from atypical endometrial hyperplasia that are the most common female reproductive cancer in the United States. Type 2 cancers derive from serous or clear cell histology. Although type 2 cancers tend to be more aggressive, diagnosis and management are similar for both types, so you don't really need to worry about differentiating between the two. Type 1 is the most curable gynecologic cancer. Vaginal bleeding, pain, and metabolic syndrome, which means that they're going to be obese, possibly have diabetes, hypertension, stuff like that. You diagnose first with physical exam and test for pregnancy as usual. Second, you do an ultrasound, right, to visualize things inside, see what's happening in there. If postmenopausal, you can do a transvaginal ultrasound and evaluate for an endometrial stripe, which is a less than 4 millimeter, unlikely to be endometrial cancer. So the endometrial stripe we actually saw in some of the ultrasounds we did. Let me go back to show you how hard it is to actually see it. And the less experience you have actually doing ultrasounds, the more impossible it will be to actually grasp an endometrial stripe. So right here, for example, in this one, this patient had ovarian cancer. And so the right ovarian endometrioma, left ovarian endometrioma, but right here is supposed to be the cervical stripe, right, like that, and you really wouldn't pay attention to that, right? It's something that you would have to learn about. This is one image that's showing it to you, but again, you can find another ultrasound of the uterus and keep trying to find it, and it's really not that easy. You have to train your eyes a lot. Further away from where you're putting the device, remember the device, the ultrasound handheld device is right up here, right? So the further away from there is down here, and there's always going to be straight lines further away. It's right up there that you want to find the endometrial stripe, right? So for example, these straight lines that you're seeing down here don't really count. These aren't the ones. Up here, there shouldn't really be any straight lines. For example, in this area, we're not really seeing any lines per se, but it is very easy to start thinking that maybe one of these is the endometrial stripe, because those three things that I just colored in red don't look too different from this one, right? So again, it's not the easiest thing to really see in an ultrasound, and it's not going to be something I would say that you guys should rely on. But verbally speaking, you can say that there should be an endometrial stripe less than 4 millimeters, and then that's a giveaway that it's not endometrial cancer. If it is endometrial cancer, then the endometrial stripe would be a lot longer. Shows thickened endometrium with hypertrophy and neoplastic changes in very advanced cases. So they have 2.128 right here, another ultrasound they're giving, different color, different everything. What you're seeing here, this is a sagittal endovaginal ultrasonogram demonstrating a mass, right? This entire thing in the lower uterine segment, endometrial canal with fluid, which is the rest of this black area, distending the canal in the fundus. And then here you have a gross image of the specimen after they must have done a hysterectomy, right? So again, ultrasound, verbally speaking, you can talk about it all you want. Visually, it's going to be a little hard to actually see it. Finally, you could do an endometrial biopsy, and if the patient is postmenopausal and any bleeding, then you must perform a biopsy regardless of ultrasound results. So if it's premenopausal patients, you can do the endometrial biopsy, it should give you the answer. If it's a postmenopausal patient and you do the endometrial stripe and it's long, then you definitely want to go ahead and order this endometrial biopsy. So what's happening in this set of bullet points here is these are going to be answer choices for your question of what's the next best step in management. All right. Treatment, high dose progestins for women who desire future fertility. If they're no longer desiring fertility, then the answer is really easy. You just do a hysterectomy and then they'll be okay. Right. Hysterectomy plus BSO with adjuvant chemotherapy is going to be necessary if it's become really advanced cancer, right? At which point it's probably going to be someone with really, really advanced symptoms as well. The question after this, the topic after this is going to be a cervical cancer. And this question up here was one where patients were confused between endometrial versus cervical cancer. So the answer here was clearly just to do an endometrial biopsy, but 25% of people chose to do a LEAP. LEAP is like this. It's a cervical cone biopsy for cervical cancer, which we'll look at when we get there. But let's look at this question to understand that this is endometrial. 42-year-old woman comes to the office for routine health exam. She is sexually active with a male partner and underwent tubal ligation for contraception. So she doesn't look forward to having any more kids, right? She has had no abnormal bleeding or recent changes in weight. Menses are regular. Last menstrual period was 3 weeks ago. 10 years ago, she had genital warts. So this is the part that made people think it was a cervical issue, because genital warts are a sign of HPV, and HPV can cause cervical cancer. Genital warts are always treated by just getting rid of it with laser ablation or cryotherapy. You freeze it off. Pap tests after that have been normal. So since they told you she had genital warts, but all her pap tests after that have been normal, it's not cervical cancer. So you don't need to think of cervical cancer in order to leap. But some people still fell for it. She has had no other serious medical illness or surgeries and takes no medications. She has a family history of hypertension but no cancer. Pelvic exam shows a normal cervix. Literally, they're doing everything to tell you what's normal. Right? Pap smear normal, cervix normal. So I don't even need to highlight that, because as you read the question, you realize that you don't need to focus on the cervix too much. Normal cervix without any lesions, a small anteverted uterus, which is not normal, and no adnexal masses. The pap test shows atypical glandular cells. So although her cervix is normal and all her previous pap tests have been normal, right now on the pap test you're seeing atypical glandular cells. So usually the pap test is to look at cells on the cervix. Now if you're finding glandular cells on the cervix, and the cervix is not a gland, it's not supposed to have glandular cells, then the only way you could have glandular cells on the cervix must be that it came from inside, which is the endometrium, right? Came out from the endometrium. So what's the best next step in her management? Well, you could either do a biopsy of the endometrium or do a biopsy of the cervix. People chose the cervix one, a lot of them, 25%, but that wasn't the answer here. Atypical glandular cells on a pap test may be due to either cervical or endometrial adenocarcinoma. All women over age 35 with atypical glandular cells, or any women under 35 with atypical glandular cells and risk factors such as obesity and ovulation, those people all require evaluation for endometrial cancer. Anytime you find glandular cells on pap test, check for endometrial cancer, because the cervix itself very, very unlikely to have glandular cells. So here you would evaluate for endometrial cancer in addition to cervical pathology. Atypical glandular cells on pap testing is investigated with colposcopy, endocervical curettage, and endometrial biopsy. Any one of those three would do the job. LEAP is a type of cone biopsy that removes the cervical transformation zone but does not diagnose atypical glandular cells on pap test. LEAP, as you can see in this picture right here, is literally a procedure that's going to get rid of the cervix. And the reason you would get rid of the cervix is because it's cancerous. Right? LEAP is a type of cone biopsy that removes the cervical transformation zone, and that's not what we needed to do for this patient right now. Right? So now let's take a look at what's happening with cervical cancer. Cervical cancer, the endocervix lies proximal to the external os, is non-visible, and is composed of columnar cells. The ectocervix is visible and composed of squamous cells. The ectocervix is what you can see from outside. The endocervix is inside. So there's a transformation zone obviously going from squamous to columnar. And that makes sense, right? That's the same kind of transformation we've seen pretty much everywhere. You want squamous cells in any part of the body that may suffer damage, get inflamed, lose cells, because then you can replace squamous cells very easily. Columnar cells are not easy to replace. The exposure of columnar cells to an acidic vaginal pH results in metaplasia to squamous cells, very much like our battered esophagus metaplasia. The normal squamocolumnar junction, which is the transformation zone, is in the ectocervix and can be exposed to carcinogens, resulting in cervical intraepithelial neoplasia, an abnormal proliferation or overgrowth of the basal cell layer. Now, dealing with cervical intraepithelial neoplasia in CK is a very bulky topic compared to what it was in step 1. It was no big deal in step 1. HPV DNA is found in almost 100% of all cervical cancers. HPV 16 is the most prevalent type in squamous cell carcinoma, and HPV 18 is most prevalent in adenocarcinoma. This is going to be very annoying because you have to memorize that. 16 for squamous cell, 18 for adenocarcinoma. So the way I memorized it is that 16 and squamous both start with an S, 18 the way you pronounce the word, you can actually spell 18 with an A teen, like that, for example. Just throwing that out there. So A for adenocarcinoma, right? So again, these are just silly little things I came up with when I was trying to memorize that, just in case there's a question where they tell you that they found HPV-16, and then they're going to be like, what's the most likely diagnosis? And the most likely diagnosis would have to be squamous cell carcinoma, not adenocarcinoma. So you can see how that's a stupid but easy giveaway question. Additional risk factors include immunosuppression, infection with HIV, or a history of STDs, tobacco use, and high parity, a lot of births, right? A lot of pregnancies. HPV vaccine may protect against HPV types 6 and 11 and 16 and 18. Can be given to both males and females from 11 to 27 years of age. Now, a lot of people didn't get it from 11 to 27 years of age. You still can request getting it even in your 30s. But for some reason, this is a very unique kind of vaccination that apparently may not work too well or may not have much effectiveness by this age for multiple reasons. For one thing, if you didn't get it up to age 27 and you've been sexually active, then chances are you probably already got HPV. And at that point, it would just be dealing with it and getting checked with pap smears regularly. But if you're like 30 and you haven't been sexually active, or you checked and you are definitely not HPV positive, then it's worth getting the vaccination regardless of how effective it might actually be. Metrorrhagia, postcoital spotting, and cervical ulceration are the most common signs. Bloody or purulent, malodorous, non-pruritic discharge may appear after invasion as well. And if you see blood, then that's more dangerous at that point. So how do you screen? Now for screening, this is where it gets very complicated. You can see we already have a bunch of bullet points here, a bunch of differences based off of age, right? And then diagnosis is even more complicated. As you can see, there's multiple steps to it, right? Very, very wordy, takes up an entire page. So this is going to be somewhat annoying to work with. American Congress of Obstetricians and Gynecologists currently recommend that screening for cervical cancer begin at 21 years of age. So basically at drinking age, becoming legal to drink. Screening recommendations for women with previously normal exams go as such. If you're under 21, no screening. So for all age under 21, just make sure to give HPV vaccine. That's the only answer choice you need to pick. So this is in red here because this must have been a question where maybe a 20-year-old girl came in for a regular exam. Everything's perfectly normal. They might throw in something, but not a red flag issue in the question. And then they'll be like, what's the next best step? Just give her the HPV vaccine because nothing should be wrong. If there's something wrong, then the question is not going to be about just giving a vaccine. So for general checkup, girl comes in under age 21, just give her HPV vaccine. Same goes for guys as well. 21 to 29 years of age, you have to start performing the pap smear every 3 years. Every 3 years, so starting from 21. And ages 30 to 65, you should continue performing the pap smear every 3 years. That's standard. Or perform co-testing with pap smear and an HPV test every 5 years. Either one works. Right? Either one is a good screening method. After age 65, you don't need to screen anymore because after age 65, if someone does get HPV, there's really not much to worry about. The cervix can easily just be removed, and you're already 65, so it's not the biggest problem anymore. Women with diethylstilbestrol exposure, terrible medication that was FDA approved and then figured out that it's really dangerous, and it's dangerous because it can cause clear cell cancer. So women with DES exposure and or immunocompromised status, such as having HIV, should continue to be screened as long as they do not have a life-limiting condition. Women with HIV should be screened with cytology twice in their first year after diagnosis, and then every year, right, once a year. Here they tell you key fact: 50% of women with cervical cancer had not had a pap smear in 3 years preceding their diagnosis, and another 10% had not screened in 5 years. Screening can save a lot of time and save a lot of trouble, so that's why this fact is here. Diagnosis. Now this is something that you again have to spend a lot of time on to really make sure you can pick the right answer choice, because all these answer choices are going to be there. Diagnosis and follow-up of specific subtypes of cervical lesion is outlined here. Co-testing is routinely done starting at 30 years of age, so HPV and pap smear together every 5 years. So number 1 here says women who are 21 to 24 years of age with cervical cytology showing atypical squamous cells of undetermined significance, ASUS, or low-grade squamous epithelial lesion, what do you do with them? Well, first of all, we need to make sure we get this. So these things look like they can be leading to something dangerous, but they do not indicate that something dangerous has occurred yet, right? You did the cervical cytology and you found some atypical squamous cells, but it was of undetermined significance, not dangerous significance. Or you found low-grade squamous intraepithelial lesion. As long as they're undetermined significance or low-grade, you completely don't really need to freak out and just keep doing repeat cytology annually. Right? That's going to be the answer choice you'll pick. If it's negative, if it's undetermined, or if it's low grade, you repeat cytology at 12 months, and if it's still negative for 2 more years, then routine screening is employed, which means you go back to the every 3 years routine. But if you keep testing and in maybe the next 2 years it becomes of actual significance, right? So you're seeing atypical squamous cells or higher, like it's no longer undetermined significance and it's no longer low grade anymore. If things are worsening basically, then you need to do a colposcopy. So colposcopy looks like this. It's basically you put the speculum there so you can visualize the cervix, and then you have your colposcope, which is basically a microscope, and you look in. And when you look inside, if you see a normal cervix, everything's okay. But if you see a cervix that looks a little cancerous with aceto-white changes like this, then that's not good, right? And at that point, you would have to go with further testing and start treatment. This is the case scenario where you would kind of sort of eventually need to treat it with this leap biopsy. See, you would just cut it out. You would just remove the whole cervix. But we're not there yet. So right now we're just saying that if you initially came with undetermined significance or low-grade squamous lesion and it's not that crazy, every year you keep checking. And if one of those 2 years that you keep checking, it looks like it's getting worse, then you do a colposcopy to directly visualize it. And then of course they have an or. Okay, so you could do all of that. That wasn't so bad. Or you could do reflex HPV DNA testing, but only for the undetermined significance part, not the low-grade lesion part. Right? The lesion requires colposcopy, but if you have atypical cells, even though they're undetermined significance, you could do the HPV DNA testing. If the HPV DNA testing is negative, go back to routine screening every 3 years. If it's positive, then you follow this above thing where you would keep checking every year, and if it gets worse, you go for colposcopy. So you see, like, this is a workflow. This is kind of teaching you how to work in essence. It's an arrow diagram in a way where, you know, it's pointing you to do this, do that, and if, you know, depending on what happens every time, you get a fork in what you should do next. So it literally is a workflow. So understanding number 1, in my opinion, wasn't so bad. You get a patient, they have undetermined significance or low-grade lesion, right? So undetermined significance, low-grade lesion. If it's undetermined significance, you could do the HPV DNA testing, and if it's negative, everything's okay. Go back to routine screening. If it's undetermined significance or low grade and you just do, you know, regular checking every year and it gets worse, then you have to go to colposcopy. Right? If everything is fine and everything keeps staying fine, then you just go back to doing routine screening. So that takes care of number 1. Now, number 2, if you find atypical squamous cells of undetermined significance in someone over age 24, then here you don't do keep checking every year. Here you directly jump to, at this age group, reflex HPV DNA testing. Check for the HPV DNA, because what is this undetermined significance actually related to? And of course, if it comes back negative, go back to routine screening, co-testing in 3 years, right? If it's positive, then generally speaking, anytime things are getting worse, the answer choice is colposcopy. Right, so that's why I highlighted the HPV DNA, but you should also underline or something, or highlight a different color, the colposcopy thing. Right, but it looks like HPV DNA comes first, which is always going to be, you know, both of those are going to be answer choices there, so you have to be very careful in picking one over the other. If you haven't yet seen HPV DNA, then you need to do the HPV DNA. But if you have seen atypical cells and it keeps getting worse, then you need to do the colposcopy, because it's already getting worse, right? And age is already playing a big role as well, right? So here, age 24, do the HPV DNA test. If there's HPV DNA, do colposcopy. Or if someone has atypical squamous cells of undetermined significance, over age 24, you can then do repeat cytology at 12 months. And if things go back to being not that bad, just go to routine screening. If next year, when I do the repeat cytology, it becomes a higher grade, then of course, logically speaking, you go back to colposcopy. So again, these ORs are just making it a little more complicated, but in all reality, after you've looked at this and then you visit it again tomorrow after taking a break from looking at this, it will make complete sense. It's not the worst workflow ever, right? It's not the worst workflow ever. What makes this a very difficult workflow is the age differentiation. So you really have to care about what age someone coming in is. Number 3, if you do the initial test, right, regardless of age, if you do the initial test and you see high grade, then you don't need to do any of these other things, right? Remember, if it's high grade, you're not going to treat it the same way you treated low grade, right? The undetermined significance or low grade, what did you do? You just told them to come back next year, check again, right? And then if it was worse, then you did the colposcopy. Here it is worse. It's starting at a bad place, so you do colposcopy right away. You go in and look at it, and if you look at it, you'll be able to see how bad it is. Now, number 4, low. What was LSIL again? Low grade squamous intraepithelial lesion, LSIL. If you have a low grade intraepithelial lesion and they're between 21 and 24, just like our first case scenario. So number 1 and number 4 kind of go together, which is the part that I don't like the most, but thankfully the answer choices are very easy here. So coming back to number 1, you have someone 21 and 24, you did the routine test and you found low grade intraepithelial lesion, LSIL. Then what do? Well, you should check HPV. If HPV is negative and they're, for more than 30 years, repeat co-testing at 12 months. That's the preferred answer choice. Okay, that's what you have to pick. If it's negative for HPV, then you just keep doing co-testing at 12 months. Next year, you do co-testing, the HPV and pap smear. Like this, pap smear and HPV, right? Between 30 to 65 is co-testing every 5 years. But in this patient, because they had the LSIL, you're just going to do it in 1 year right now. And next year when you do it, if it's negative, you go to doing co-testing in 3 years, not 5. Right? You, of course, want to check more frequently because something has already kind of sort of raised the flag. Now, after this testing stuff, if things start to get worse, everywhere the answer is the same. Okay, so very, very straightforward. Basically, you don't do colposcopy until things get worse. That's the general theme of the story here, and we're going to see that in our questions. If unsatisfactory or no visible lesion, then of course you need to do an endocervical sampling. You need to go deep inside and look at the cervix, right? Make sure that you can actually see what's happening. For pregnant women, colposcopy is preferred, but can defer until 6-week postpartum. So basically, if someone pregnant has LSIL, you shouldn't do anything right now. Wait for them to deliver first, and then postpartum, check what's happening. Because you're not really going to do a colposcopy and a leap biopsy here in a pregnant woman. That can, as we already saw in obstetrics, lead to immediate labor and delivery, and it might not be the right time. So there's no urgency, there's no point, because it's still only LSIL. Only LSIL. This is not going to lead to immediate cancer in the next month or 2. AGC, atypical glandular cells. All women with cervical cytology showing atypical glandular cells should have colposcopy with endocervical sampling for biopsy. Women over 35 years of age or those with abnormal bleeding raising concern for endometrial neoplasia should have colposcopy with endocervical and endometrial sampling. So this is for atypical glandular cells, not the ones we just saw over here. These were atypical squamous cells of undetermined significance or low-grade squamous cells in the intraepithelial lesion, right? But number 5 is talking about glandular cells, which was actually related to the question we just did up here. Right, all the way up here, this patient had atypical glandular cells, not squamous cells. So for atypical glandular cells, always you have to do endometrial checking, right? Because that raises concern for endometrial neoplasia. Number 6, now we're talking about high grade stuff in a young person, right? So atypical squamous cells of high significance or high grade squamous intraepithelial lesions in a 21 or 24-year-old, at this point it's already really bad. So you're not going to be like, oh yeah, go back, I'll see you again next year. No, right here you're going to jump straight to colposcopy. Right, and then when you do the colposcopy, if the lesion is level 2 or 3, or if things are just looking really bad, which is what lesion 2 or 3 means, then you have to jump to treatment. Right, so all of these lead to treatment once you get to the point where things are bad, right? Where you have to do the colposcopy. If things are looking really bad, it jumps over down to treatment. Number 7, high-grade squamous intraepithelial lesion in someone over 24. That's the breaking point, right? 21 or 24 or over 24. Then if they're over 24, here you do immediate loop electrosurgical excision. Except if they're pregnant. If they're pregnant, you wait until they deliver. All right. So now we go to treatment. For non-invasive disease, treatment based on biopsy results for non-invasive lesion is as follows. This is for non-invasive stuff. If it's CIN1 that was previously undetermined or low grade or HPV positive, then follow-up is the mainstay of treatment. Okay, right here, very important answer choice. Things may look really, confusing in a question, but if CIN1 and before CIN1 it was undetermined and low grade, it's okay. You keep follow-up. You don't do anything here because it's not of that level where it's so bad you have to do surgery. Co-testing at 12 months and colposcopy if it gets worse. Okay, if it's not getting worse, resume routine screening. Very, very straightforward. But if it was CIN1 and it was actually preceded by a high grade, then you need to continue doing co-testing, and if it gets worse, then colposcopy, and if it's really getting problematic, you're going to probably have to do the surgery. But at this point, CIN1, all we're seeing is that you just keep screening regardless of how bad things are, right? Because it's CIN1, we're considering that the intraepithelial or neoplasia lesion is level 1. But before that, it was a high grade thing or it was a low grade thing. It doesn't matter. You keep screening, right? At this point, you're just screening. CIN1 for 21 to 24 years age. For again, patients that are 21 and 24 or pregnant, keep repeat cytology. As you can see, just keep doing cytology until you find that it is very bad. Right? CIN of high or higher, colposcopy. Nothing crazy as an answer choice yet. Everything is just colposcopy. That's all we're seeing here. Repeat testing until it gets worse, then do colposcopy. Even in treatment, just like we were seeing in our diagnosis chapter, diagnosis part right up here. If it reaches to CIN 2 or 3, these are the higher levels of danger. So if it reaches CIN 2 or 3, then at that point, ablation, excision, and actual surgical procedures become a more significant answer choice. It's a problem now, right? In young women, you can observe with colposcopy and cytology at 6 and 12 months, but we're talking like not their age, but after you found CIN2, 6 months after that, you check again. 12 months after the initial thing, you check again. Basically checking every 6 months, which is pretty frequent compared to checking every 3 years. Post-ablative or excisional therapy is as follows. If it's CIN 1, 2, or 3 with negative margins, then you just keep doing pap smear. If it's CIN 2 or 3 with positive margins, you do pap smear even earlier, right? More common, more often. Treatment based on biopsy results for invasive disease is as follows. So if it's invasive, then you have to do treatment based off of where, how invasive is it. Microinvasive carcinoma is stage 1. You just treat with a cone biopsy and close follow-up. So a cone biopsy is different from LEAP, as we can see in the picture up here. LEAP only took out the cervix. But if it's invasive, then you do a cone biopsy where you take out more of the tissue here. Because it's invasive, so it's gone in a little bit. The cancer has gone in a little bit, so you take out more of the cervix than you initially were with the LEAP. Both of these are going to be answer choices, LEAP and cone. Stages that are higher may be treated with either radical hysterectomy, where you take out the whole uterus, which means you also get the cervix out, or with radiation therapy plus chemotherapy alone. And if it's really bad, going to stage 4, then you need to do radiation and give medications like cisplatin, chemotherapy. So you can see how bad it can get. The cervix can become really, really messed up, hard, and painful. you would have to get the whole hysterectomy thing done. But the invasive aspect is requiring chemotherapy as well, cisplatin, right? They do a nice thing here, giving you the stages, showing you how it all looks like, how they're numerically labeling the stages and what makes it a certain stage. So this part is really just to visually help you see. As you can see, in stage 4, things are really bad, so you're going to need systemic medication because it has invaded the bladder and the colon. Right, so it's becoming pretty much systemic at that point, and it can lead to a lot of problems. You don't want it to get that far. Usually, a question will never show you stage 4 unless it was a patient that hasn't seen a doctor in like 10 years, something like that, or someone who just immigrated, where in another country checking for HPV related cervical things may not be routine. Like in India, in many of the poorer parts of India, or the smaller, not so prominent parts of India, checking for pap smears routinely is not a thing. Really not a thing. And even in the richer parts and the more prominent parts of India, women don't really tend to go for routine gynecologist appointments or getting pap smears and stuff. It's not really a common practice there. Female hygiene is not really the biggest topic in many countries as much as it is in America, in the West. So watch out for questions where the patient recently immigrated, because that always means a lot no matter what the topic is. Prognostically speaking, overall 5-year relative survival rate for carcinoma of the cervix, 68% in women, 55% in African American women, white women versus African American women. The 5-year survival rates are inversely proportionate to the stage of cancer. The worse the cancer, the lesser the 5-year survival rate. Almost 2/3 of patients with untreated carcinoma of the cervix die of uremia when ureteral obstruction is bilateral, right? Because you can see how it's going to start obstructing the ureter. Right? It's going to grow out, it's going to start obstructing the ureter, and it can spread to anywhere from that point on. All right. So now let's take a look at some of these questions. First one here, 37-year-old woman. So she's well over the 24-year-old barrier that we care about, right? There's 21 and 24, and then over 24. 37-year-old woman comes to the office for evaluation of abnormal vaginal discharge. Okay, she noticed increased clear watery vaginal discharge 4 months ago and now has intermenstrual bleeding. She reports no pruritus or dysuria. So far the key symptom is intermenstrual bleeding here. She is sexually active with a male partner and uses condoms for contraception. She has had 5 lifetime sexual partners, no medical problems or previous surgeries, 24-pack year smoking history. Alright, so she smokes, vitals are fine. Pelvic exam, this is the part we care about. You see a raised ulcerative lesion on the cervix. So I'm just going to highlight cervix when I read this in a question, because I can always find the word cervix when I go back to skim at the question and then quickly look at what it was about the cervix I cared about. So raised ulcerative lesion is noted on the cervix, and clear discharge is present. So clear discharge means it's probably physiologic discharge, not like trichomoniasis or any other infection. The vaginal mucosa is not erythematous, has no lesions. Uterus is small, mobile, and anteverted with no adnexal masses or cervical motion tenderness. There's no inguinal lymphadenopathy. What is the best next step in her diagnosis? And here the answer was cervical biopsy. Okay, so why cervical biopsy? And why not one of the other things we just looked at over here, right? We just saw all kinds of things. So again, we're not looking at number 1 because she's past this age. We're not looking at number 4 because she's also past that age, right? Number 2 we care about, but we don't know if what we're looking at in our question is atypical squamous cells of undetermined significance, right? They didn't say that in the question, so we can't really use number 2. Number 4, again, we don't know. LSIL, we don't know if what we're looking at is a low-grade squamous intraepithelial lesion or not, but they did describe it pretty well. So what they described here, right, in this question, a raised ulcerative lesion, that doesn't sound like squamous lesion, right? It doesn't sound like, but it could be. So we're not 100% sure, what's actually happening here. After that, we come to this area, so we don't care about this age. We do care about this part right here, and considering the fact that it's an ulcerative and raised lesion, it probably is not something that's a low-grade lesion. So most likely it is a high-grade squamous intraepithelial lesion, and she is over 24. So what do? We do LEAP, which is practically a biopsy, right? Cervical biopsy. Cervical cancer is most commonly asymptomatic and detected only during screening, which is why screening is so critical. When symptoms do occur, as in this patient, they can include vaginal discharge, postcoital bleeding, intermenstrual bleeding, and a cervical lesion. Lesions that are suspicious for malignancy are going to be labeled as ulcerative, friable, or raised, particularly in patients with risk factors, which she has, right? She's had multiple lifetime sex partners and she smokes. Advanced cervical cancer may present with symptoms of local invasion, including a large vascular cervical mass with heavy vaginal bleeding. Now, you can rest assured that for this question, colposcopy was an answer choice too. But remember when you would order colposcopy. Colposcopy was always ordered when things were getting worse, but they started with something that wasn't so bad, right? And almost all the colposcopy we saw here was for patients that are age 21 to 24. Right? As soon as we got to over age 24, we don't really see too much colposcopy. It is an answer choice, but the better thing for her, where they're already verbally describing the lesion, would be to do an actual biopsy before things get worse, because you don't know how long she's had it for, and you really need to grade the lesion, not just look at it. Okay, so very good question, and this topic, I promise you, is one that will often be very intimidating, because when you read the question, you're really going to have to think hard about what's happening, consider the age, consider the symptoms, and how does the cervix actually look. And if in the question they start describing it as ASC or HSIL or SIL, then it becomes even harder. And I think that happens in one of these questions. Let's look at this one. So here again, we're looking at a girl that's over age 24. This is a 27-year-old woman, G2P1 at 28 weeks gestation, and she's pregnant. So we saw with pregnancy that we wait, right? We don't do anything until after the delivery, but you can do the colposcopy to look at it, but not any kind of biopsy or cutting anything or taking off the cervix, none of that, because that's going to lead to delivery. She feels fetal movement, has no vaginal bleeding or contractions, and has had uneventful pregnancy to date. Her previous pregnancy 5 years ago was fine. She has not had a previous abnormal pap test, but the last test was performed during her prior pregnancy. She has no medical issues or previous surgeries. She takes a multivitamin and an iron supplement. Doesn't smoke or drink. Vitals are fine. Fetal heart tones are fine. Physical exam reveals a gravid, non-tender uterus. The cervix is long, closed, firm, and posterior, and the fetal presenting part is high. So all of that is obstetric information, and it's all normal. The pap test showed a high grade, look at that, high grade squamous intraepithelial lesion. That is HSIL. Right, HSIL. What is the best next step in her management? So high grade squamous intraepithelial lesion basically means that she is about to develop cervical cancer and you really have to do something about it. But she's pregnant. She's 28 weeks in. She has about another 12 weeks to go. We give it to her, right? So here the answer was immediate colposcopy. 40% of people picked it. Now look at what the other people chose. 30% chose repeat pap test postpartum. We already see high-grade intraepithelial lesion. There's no reason to do a pap test again later because it's still going to be high-grade. A high-grade lesion doesn't go away by itself. So the 30% that chose that, it made no sense to pick that, right? If you're checking someone's colon and you find a polyp, you don't just do a colonoscopy again in a year because that polyp is still going to be there, right? So what are you looking for? So this repeat pap test answer choice made no sense. 20% chose HPV co-testing. Now, that answer choice, checking for HPV, is something that you could do, you know, and again, it's a more respectable answer choice in my opinion, because doing the colposcopy, going in and looking at it and everything can actually trigger contractions and trigger delivery, right? But let's look at how they explained it. So, a pap test is a screening exam for precancerous lesions of the uterine cervix. High-grade squamous intraepithelial lesion on pap test is concerning for underlying severe neoplasia or invasive cervical cancer. All patients require evaluation with immediate colposcopy. Repeat pap testing is stupid. Colposcopy evaluates the cervix and vagina under magnification after application of acetic acid to contrast and identify abnormal changes from normal cells, which you can see here, right? It's going to look different color. Cervical neoplasia occurs at the transformation zone or squamocolumnar junction. If these areas are not visualized during colposcopy, an endocervical curettage is performed to evaluate the endocervical canal. Endocervical curettage is an invasive procedure, and you should not do it during pregnancy. Cervical biopsy is performed even in pregnancy if a lesion has high-grade features. Right. So again, like, the safest answer choice was to just do immediate colposcopy because you care about the mom more than you care about the fetus right now, and it's already high grade, not just a low grade thing where you could be like, all right, we'll just wait. Right. And with low grade, it would make sense to do a repeat pap test later to see if it became high grade, and then when it becomes high grade, you do the colposcopy, and after the colposcopy, you could do the biopsy and actually just get rid of it if you need to do LEEP excision. Right. That's the workflow you have to follow basically. So again, another very good question to help you kind of see how you manage the workflow. Here's another tiny question that was very straightforward. This is a question where the girl actually falls within the 21 to 24 range. A 23-year-old woman comes in for routine care. She's currently not sexually active, pelvic exam is fine, and you do the pap smear and you see dysplastic cells consistent with CIN level 1. What's the best next step? Colposcopy. Right? We see that here. Right, we see that they're saying it's CIN1. Basically, it's not ASUS, it's not LSIL, it's actually CIN1, which means that you kind of came all the way down to this level. Right, and you can see that if it's CIN1, doing colposcopy makes sense. Right, doing the colposcopy test, looking at this plastic cell makes sense. It's not just ASUS. ASUS, a 23-year-old woman with ASUS, you would just do repeat cytology at 12 months, not colposcopy. Right, but CIN1 basically fits into this category where you do colposcopy. A 21 to 24-year-old woman with something higher grade, you do colposcopy, not repeat cytology or HPV testing, none of that. Right. In this question, they could have HPV testing as an answer choice, but I don't think it was an answer choice, or I would have probably written that here. That would make it very confusing because that would also be a good answer choice. Right, you could just do a reflex HPV DNA testing as well. All right, but again, HPV DNA testing, you can see here they've written, is really something you just do when it's undetermined significance. With a dysplastic cell of CIN level 1, when you started calling it CIN level 1, you pretty much already know that it's consistent with HPV. So just do the colposcopy, take a look at it, and see how bad it is. Right, how problematic is it becoming, and then management will be based off of that. And then I think there was, yeah, that was basically it. So in our next session, we'll look at the rest of these questions up here and then dive into what's left, what's after this. The next thing was, yeah, so we're done with that. Then we'll move on to vulvar cancer. So we'll look at those practice questions and move on to vulvar cancer.